Hi, and welcome to this edition of Duffy Doings, our show about issues related to healthcare and homelessness on Cape Cod and what's going on at Duffy Health Center. Today, I'm really excited to have with me as my guest, Dr. Lisa Zandonella-Huhta. Lisa is one of our physicians at Duffy Health Center, and she's the doctor that works mostly with our patients who are in addiction treatment. Great. Welcome, Lisa.
Oh, thank you.
Glad to have you here today.
To be here.
And what we're going to be talking about today is the science and medicine of addiction, and also talk about the topic of medication-assisted treatment. Okay. You know, everybody on the Cape has been talking about the issue of addiction to heroin and opiate pain medication, largely because the statistics are so shocking that the sharp rise in opiate overdoses and in overdose deaths since 2012. I heard a radio interview the other day with the police chief from Gloucester, Mass. He's the one who has the new policy where anybody who comes into the police station and is addicted and wants to seek treatment, rather than locking them up in jail, he'll find a treatment spot for them. But what he talked about was that he thinks the reason why the problem has become so much more serious is primarily two reasons. One is the availability of heroin, and then also the relative low cost of heroin. But I think really what scares people so much about heroin and opiate addiction is that it happens so fast, and that somebody can change so quickly it may feel like it's even overnight. Can you tell us something about how I've heard you say in the past that addiction is a relapsing, remitting disease of the brain. Can you explain what you mean by that?
So a couple of interesting things, and I learned this a little bit ago myself. So drug addiction was first described in the 1700s. And then in 1987, the American Medical Association, the AMA, recognized addiction as a disease. There are 8 to 10% of people 12 years of age and older, that's 20 to 22 million people that are abusing either alcohol or some form of drug. This is about $700+ billion that are being lost in wages, spent secondary to crimes, and also with health care, because there's a lot of health care costs involved with folks that have addiction. So I think to understand addiction, you have to first understand what the definition of addiction is. So there's an organization called ASAM, it's the American Society of Addiction Medicine, and they drafted the definition of addiction, and they have a short version of this, and I wanted to just read that quickly to you. So addiction is a primary chronic disease of the brain, reward, motivation, memory, and related circuitry. Dysfunction in these circuits leads to characteristic biological, psychological, social, and spiritual manifestations. This is reflected in an individual pathologically pursuing reward and/or relief by substance use and other behaviors. Addiction is characterized by an inability to consistently abstain, impairment in behavioral control, craving, diminished recognition of significant problems in one's behaviors and interpersonal relationships, and a dysfunctional emotional response. Like other chronic diseases, addiction often involves cycles of relapse and remission, and without treatment or engagement in recovery activities, addiction is progressive and can result in a disability or premature death. So it is a psychosocial, biological, spiritual disorder. And so it's a very complex disease. But as time goes on, it is a chronic disease of the brain, and the science is showing that. So I'm going to tell you a little bit about the science as best I can. It's a little simplistic, but anyway. So it's really about the reward circuitry that's located in the primitive part of the brain, and the neurotransmitter dopamine. All right. So dopamine is central to anticipation, reward, and punishment. All right. So then another part of this is the prefrontal cortex. And the prefrontal cortex is responsible for our higher cognitive function, self-control, impulse control, and most importantly, consequences. This part of the brain does not mature until the person is in their late 20s, early 30s. And so what happens is when a person, the most common time a person starts to take drugs or substances of abuse is in their adolescent years. And so this prefrontal cortex is offline. So, you know, kids feel that they are indestructible. They really do not have that consequence piece down at all at that point. So with the dopamine is usually released when you have with life-sustaining behavior. So, for example, if you're hungry, you eat so you don't die of starvation. If you're thirsty, you drink so you don't die of dehydration. And you know, continuing the species, reproduction, and parenting. So what happens is if you get a perfect storm, which is genetics, 50% of addiction is genetics. You get environmental issues or concerns, changes. You have trauma, whether it's post-traumatic stress, trauma any time in life, especially in adolescent years, peer pressure, mental health disorders. If you're from a family where parents are abusing or taking drugs, they have a different view of what a drug does. It's a different teaching environment. So they may voluntarily take the drug initially, but after they take the drug, this addiction takes on a life of its own.
I see.
Okay? So when a person abuses opiates, you have a surge of dopamine that is 2 to 10 times normal.
Wow.
It's faster, it's longer lasting, and the person feels like they can do anything. They feel safe, they feel warm, they feel empowered. I've had patients come in and say to me, you know, I'm terribly shy, but when I took my opiate, I could go to a bar and I could meet people and I could talk with them.
Interesting.
And it gave them a sense of feeling safe.
Sure.
So what happens though, because it's such a high dose and such a high intense release of the dopamine, the brain tries to compensate by decreasing the amount of dopamine. You also have in your primitive brain, you have the anti-reward circuitry, and this is driven by a different neurotransmitter, which is called glutamate. And so now they're out of balance. So when the person stops taking the opiate, what happens is the anti-reward circuit kicks in. The person feels flat, they feel lifeless, they feel depressed. And this is when folks come in and say to me, I'm just taking an opiate now to feel normal, to get up in the morning, to take care of my family, to go to work, to do what I need to do every day. So the brain is really good at remembering every aspect associated with this sensation, and it stores it. It stores it with persons, places, times, things, smells, visual cues. And what happens is, this is like Pavlovian, remember Pavlov's dogs?
Sure.
Pavlovian learning, so that what happens is the person starts to respond to the anticipation. You don't even need the opiate anymore. And this is when people relapse.
Oh.
All right?
Okay.
So they say to you, I left here, I was not going to use any more opiates. I don't want to use any more opiates. I know all the consequences. But when they go out and they face those triggers, what we call triggers, they relapse. They come in the next week and they say to you, I'm really sorry. Next thing I know, I was using the drug. I didn't even want it. It didn't do anything. I don't understand what happened. All right? So this is why it's really important. Treatment, it seeks to restore the balance between these systems, the reward, the anti-reward, and the higher executive portions of the brain. And this is where medication-assisted treatment comes into play.
That's fascinating, Lisa. Thank you so much for
You're
that
welcome.
explanation. That
You're
is
welcome.
really helpful.
So it's really, truly a science.
And it really...
And there's much more to understand.
And it helps one to understand about the age, you know, what happens developmentally with different parts of the brain.
Yes.
Well, and because there are many different pathways to addiction, we know that there are also many different pathways to treatment.
Correct.
So some people are able to quit cold turkey.
Yes.
Other people quit by going to a facility where they receive a detoxification or detox, as we call it, and then they go into rehab, as we normally call it, but a place where people stay, like a hospital.
Exactly.
For a certain amount of time, and then may actually go into residential treatment afterward. And then there's also medication-assisted treatment, which is where we're going to go next with our conversation.
Yes.
But Lisa, I think everybody would be really interested to know more about you before we head there. How did you get interested in being a doctor, and certainly how did you get interested in this field of addiction medicine?
So I actually started out as a nurse, and I worked in intensive care for many years. And then I decided I love medicine, and I wanted to do something more in medicine. So that's when I applied to medical school, and I was accepted. With addiction, actually that started when I moved to the Cape. And I started working with Judy Bess-Lavignac at the shelter. This was back in the early 2000 time. And we were meeting the needs of our homeless population with regards to medical as best that we could. But we noticed that, you know, it was eminently clear that there was a huge addiction problem with our patient population, and this is known. And at that time, when I started back around 2000, that there wasn't Suboxone, or there weren't any medications that you could help them with. You could try to address their needs through behavioral changes if you could, you know, engaging them in treatment of other kinds and try to talk with them. But when Suboxone became available, which is a combination medication of buprenorphine and naloxone, we'll talk more about that later, we said, let's do this. Our folks need this. Let's start a program.
Well, and the Food and Drug Administration of the federal government approved it for use around that time, right?
Correct.
2000, 2001.
DATA Data 2000. And it's very complicated, but and it's very lengthy. But the bottom line is that because buprenorphine is an opiate, it behaves differently than other opiates. I'll explain that later. They had to make it a different schedule in order for a primary care provider to schedule it through their office.
I see.
Medications like methadone have to be prescribed through special programs. So the primary care provider cannot prescribe methadone to treat a person with addiction. Right.
You know, I think it's really important to talk just very briefly about the connection between homelessness and addiction. Very similar to the issue of homelessness and mental illness, is that we do see a high experience of mental health and addiction with our homeless population. But I always say, you know, one can cause the other.
Absolutely.
So somebody in homelessness becomes depressed, becomes anxious, suffers from mental illness, but also somebody with a serious mental illness that's untreated can easily become homeless. And it's the same for people with addictions. People can develop an addiction and lose everything and become homeless. Sometimes people use drugs and alcohol as a way of coping. With their homelessness. So it's wonderful work that you do when you think about it.
Rewarding.
So I don't know that people know a lot about medication-assisted treatment. You know, when I work with the Regional Substance Abuse Council and when I speak in, you know, with different community groups, it doesn't always come up. People always want to talk about, we don't have enough residential beds, we don't have enough detox beds. Medication-assisted treatment is something that we can do on an outpatient basis, which is very attractive, and people don't have to go through withdrawal or cold turkey or that to use these medications. So can you talk more about that? How do the medications actually work?
So there are three primary medications at this point in time. There's many others coming down the pipeline, as well as other types of treatment. And the three are methadone, buprenorphine, which is a component of Suboxone, and naltrexone. And naltrexone in the injectable form is called Vivitrol. And what we're looking at is these medications all work on the mu receptor in the brain. Now you have your mu receptors over your entire body.
Okay.
And when you take an opiate or an opioid, it affects all mu receptors. But depending on where they are in your body determines the effect it has. We're talking about the mu receptors in the brain.
Interesting.
Okay. So the way methadone works is it's called an agonist, and it's what's called a full mu agonist. And an agonist is something that activates a receptor. So methadone attaches to the receptor perfectly. So I'm going to use the analogy of a door.
Okay.
All right. So when you take methadone, it attaches to the receptor and it opens the door. And the more methadone that you take, the wider the door opens. So you get more of an effect from the medication. But the problem is then you start getting into side effects. You get into the serious side effects of respiratory depression, coma, and death if you take more. All right. Now, buprenorphine.
So you could overdose from methadone. Okay.
Absolutely. And that's why it's so carefully regulated and controlled. Now, and buprenorphine is too, but you have to use a different program. So buprenorphine, it fits in the mu receptor, but it's not a perfect fit. So the analogy for that is if you put a chain on the door. And so when you give the person the buprenorphine and it attaches to the receptor, the door opens, but the chain only allows it to go a certain distance. And it doesn't matter how much more you take, that door won't open any further. And that's called a ceiling effect. So the chances of overdosing on buprenorphine alone is very, very low. However, the people who get into trouble with buprenorphine is when they take it with another drug.
I see.
When they take it particularly with the benzos, alcohol, and folks can overdose and die when
So
they
something like
mix
Valium, if somebody
Valium, Klonopin, Xanax, Ativan. So that's when it becomes a real problem. Now, the reason you take these medications, the agonists, is the agonists prevent craving, they prevent withdrawal symptoms, and it gives the person the ability to work on recovery. Okay. The last one is the naltrexone or Vivitrol. Now, naltrexone works also at the mu receptor, but it's called an antagonist, which means it doesn't stimulate the mu receptor. So that's like closing the door and locking it.
I see.
So no matter how much opiate the person takes, the door is locked. It's not going to open. And so what happens is the person doesn't get the sensation that they are after or what they need, what they feel they need, and they stop taking the opiate or alcohol. It works for both. However, the problem with this is if somebody tries to override it and take a lot, you can still get the side effects of overdosing on the medication, on the drug that you're taking at that time.
I see. So at Duffy, we don't offer methadone treatment. We refer to other agencies that do that, but we do prescribe Suboxone and Vivitrol. How do people hear about our programs? We have over 200 people now in our programs. Are people referred by friends and family? Are they? Is it word of mouth? How do people hear about our program?
So I find in talking with our patients that a lot of it is word of mouth. I have patients coming in and telling me that they're so-and-so wants to come. I tell them about the program. I'm trying to get them in to see you. They will actually bring patients to us and stand next to them and go through the whole process of registering and being supportive. We get a lot of referrals from the jail. We get referrals from the ERs, the local ERs. We get referrals from other agencies. The OBGYN docs will often refer patients to us. So there's lots of different avenues that patients can come to our clinic.
I see. Well, and you mentioned the jail, and we also work with the probation department. In fact, Sheriff Jim Cummings is coming to Duffy next week to give us a little recognition for working together, for being a good community partner. Primarily, we started prescribing Vivitrol because the jail
Correct.
asked us to. So
Yes.
why is Vivitrol a good choice for people who are in jail?
So what's really good about Vivitrol is, first of all, it's not an opiate, all right? That's sort of important. The other thing is when you give a person Vivitrol, when you give them the injection, it's a long lasting. It lasts for 4 weeks before they need another injection. So it gives the person time to come to the clinic, get established. There's a lot that goes into doing what's called a prior authorization to get the medication because it's very expensive.
The insurance companies.
Yes, and it's a very expensive medication. So there's a special pharmacy you order it from, and that takes about a week or two. So we end up having to order it in advance, and and that gives us this wonderful window to do that, and then we can just keep going with the injections.
Right. Well, and then the other reason I think why Vivitrol is a good choice is that people generally have all the opiates out of their system.
Correct.
And you have to have all of the opiates out of your system for
before you
Vivitrol
start
to
it.
work, right?
Exactly.
Okay.
The other thing too is that most folks are not just abusing opiates, they're abusing alcohol and opiates. And Vivitrol works very nicely for both alcohol and opiates.
Right. Our other physician, Dr. Klein, says he really likes prescribing Vivitrol for people who have serious alcohol addiction.
Right.
So, and then we have a great partnership with both courts and the probation departments here in Barnstable County. But interestingly, people who come because their parole officer says they have to come may not be the most motivated for treatment. How does that work?
So actually it works out well, and the reason why is because when folks initially come to see us and they have court or probation or they're on colors, they're motivated. Their whole heart might not be in it, but it gives you the opportunity to work with them. And it's very interesting. I would say the far majority of the time, once probation is over, they've reached a point where they're like, this is how I want to be. I don't want to continue abusing drugs. I like where I am. And I want to keep going. So it actually is a great opportunity to engage folks. We not only engage them around their addiction, we engage them around their behavioral health and their chronic medical diseases as well.
Well, and that leads right into the next question, which is about how Duffy's program is different than other programs. We have, since we started working in medication-assisted treatment, had received funding from the state, from the Bureau of Substance Abuse Services, to lead a partnership with all of the health centers, community health centers on the Cape to start medication-assisted treatment programs. The Commonwealth really wants to encourage the normalization of these kinds of treatments, and that it reduces the stigma if people are able to just go into their doctor's office and receive the treatment. So we know community health centers have the right model. And there are other private physician offices that also prescribe medication-assisted treatment across the Cape. But can you talk about what it is that we do that you think may distinguish us as a provider?
So when Suboxone, buprenorphine, naloxone, the combination medication became available, when in order for a primary care provider to prescribe it, they had to be waivered. And once the waiver was in place,
and the waiver is from the federal government?
Correct, the DEA. And so what happens is, originally they said, listen, it would be best if you could refer the patient for behavioral health services. You just have to be able to do that. It wasn't mandatory. So when Judy and I started the program back in the early 2000 time, we said, listen, let's make ours different. We're going to make behavioral health mandatory. And that's what we did. So we said folks need to be doing they need to take care of their chronic medical diseases like their diabetes, their hypertension, their Hep C, their HIV. They have to be engaging in behavioral health services and case management services as needed. The other thing, and that interestingly is becoming the model even out in the private sector, because they're finding more and more that you really have to do the behavioral health piece in order to look towards recovery.
Right.
Okay, recovery takes many forms, but you need the behavioral health piece. We also have very comprehensive contracts and consents that the patient signs. We hold folks accountable. We do what's called random urine drug testing or screening. And we use that as a tool to work with the patient. Studies recently, and it's like no surprise, are showing that if a person is abstaining from all substances of abuse, their chances of recovery is much greater. Right. And so we use this as a tool and encourage folks to abstain from pot, alcohol.
So you can look and see if they're using other substances, but also if they're taking their Suboxone to make sure it's in their bloodstream, yes. And working with them on that, really important. So none of this would be possible without our amazing staff at Duffy Health Center. Yeah. And we've already talked about you and Dr. Klein as the physician leaders. You are obviously the leader of the program. And we have two nurses who work in this program and work with our patients on a regular basis. What is it about those staff that make them so special?
So I have two wonderful what do we call MATRN case managers. John has been with me for many years now. He is a certified addiction nurse specialist, and crazy proud of him. And I could not run the program without him.
And I think didn't we find out there's less than 100 across the whole United States. So we're very proud of John.
We're really proud of him. And so if I couldn't run the program without him, he keeps it organized. He runs a group where we have in the area of 16 to 17 people that attend that group monthly. He runs that with Louise Patrick, who's one of our who's the director of behavioral health and a therapist who works with our folks as well. We also have Alicia Gapster. She's new to us, but she has a lot of experience in the field of addiction medicine, having worked with John. So she was a nice find as well.
And that's how we were able to expand from 130 or so to our 200,
to our 200
patients. Well, we're really getting close to running out of time. One of the things that we will have to come back another time and talk about is new funding that we have received from the Commonwealth, from the Bureau of Substance Abuse Services. They have received funding from SAMHSA, which is the Federal Substance Abuse and Mental Health Services Administration, to expand what are called evidence-based practices in treatment with youth. And the target population are 16 to 25. And up to this point, we have been in adult practice. Our patients are 18 and over. So sometime within the next 6 months or so, we'll start working with younger teens who up to this point have had to go all the way to Boston. To be able to access Suboxone. So we're very excited about that. And I want to thank you so much for taking the time to be with us today.
My pleasure.
And that's it for this edition of Duffy Doings. See you next time.
Thank you.